to just touch a little bit on a little bit different area. Uh, First, my disclosures here. And if you look at this slide, this is a study we did looking at the trend in robotic surgery. This was for gynecologic oncologists. And I think the most important thing you can take from this is every surgeon who's in training at this point or who's already trained wants to finish majority and learn a lot of robotics with minimal amount of effort through courses and not spend a lot of time. Meanwhile, do they feel that they want to pursue a fellowship in robotic surgery? Majority of them do not want to pursue a fellowship in robotic surgery. So trying to find an easy way of trying to learn and get trained in robotic surgery. This is a study we did in 2006 where we tried to look at the importance of robotic training, and you can see it differs from faculty, fellows, and the perception faculty have, residents have, what training and how training should be done, and what if they wanted to pursue a fellowship. And you can see at the level of the residents, majority of them do want to pursue a fellowship. And one of the examples which you'll see later during this session towards the end, a lot of people who trained at Ford ended up doing fellowships in robotics. The current issues, at least in this country, work hour limitations, the litigation issue, the cost of training people, removing the limitations, removing the surgeon training from the ORs outside, and then also shortening the learning curve, and in the end, validating, enhancing, and maintaining these skills, very critical to understand these things. Looking at surgical simulation, this is a very nice paper which was about a decade ago showing when they evaluated the percentage of program directors who felt that it was needed. Almost 70% of the program directors feeling that surgical simulation was needed. And in the last decade, minimum has been done, especially in urologic sciences and robotic surgery. Well, what are the limitations of surgical simulation? You can see that some of the limiting factors and obstacles towards surgical simulation is majority of the people think that patient care responsibilities are higher, the lack of facilities, work hour limitations, and the desire for people to spend time in simulation is minimal because they feel that they really want to go directly to the operating room. And again, from Prokar's group here, Dr. Darzy's article, very nicely showing that what limitations box trainers have and porcine models have, and virtual reality really bringing the field forward safely for us. So very nice slide from BMJ looking at comparing the attitudes of aviation and healthcare, how people get trained, and you can see pilots who answered yes, does fatigue negatively impact your performance, and majority of the pilots yes, and look at the surgeons or the physicians or medical related field, and do you reject advice from juniors, only 3% and 45% here, and here 100% in pilots, they do think that they make mistakes, they easily discuss mistakes and outcomes, and look at what happens in physicians and the limitations we are facing in our field. When I left Ford, we started doing some research and developed a simulator and tried to get some simulation work done in our lab and came up with a simulator which technically tries to portray or come up with a solution outside the operating room and try to see if we can come up with a solution to make people train and learn outside the operating room. And this is our robotic surgical simulator, commonly known as the ROS, discussed by Dr. Badani earlier. And you just can see that almost has had face validity studies and training modules, and now Da Vinci has come up with a backpack with the Mimic software, which has done similar thing. This is our initial content validity, looking at the usefulness of training residents or medical students, and you can see majority of the people feeling that how important and how useful ROS was, and recommending ROS for further and future training for residents. And this is another study part of the study looking at the 3-4 modules of training for basic surgical curriculum and showing that majority of the people felt that it was good to excellent, and minority feeling that it still needed some improvement, especially in experts who are comparing it to the Da Vinci machine directly. So the bottom line is this, so where do we go from here? Do we still operate with simple boxes and beads, but that is really not the future. Medical simulation has to get real. And in a lot of areas, if you look at surgical simulation and medical simulation, it has gotten real when you are talking to credentialing for anesthesiology or critical care. A lot of this has happened, but this is totally different than what surgeons do in the real operating room. And we have tried through our research to take this to the next level using image-based virtual reality to teach anatomy. This is a study we did comparing regular study where a group was taught based on curriculum, books, and illustrations versus when they were taught on ROS, and you can see the mean time to completion of identifying anatomy, the number of errors reduced dramatically, and the number of correct answers was excellent with the simulation-based group, and showing that really the next area should be where simulation is used for education starting from the medical student level. We have this other technology which hopefully in a few months we should have a procedure available, a hands-on surgical technology where last 3 years of work has been put in and using haptic-enabled augmented reality, and we have finished the patents on this, and technically the ROS practically hosts a trainee and takes them to the next step and are able to perform a procedure. Hopefully in April, we are coming out with the prostatectomy, in June hysterectomy, and a nephrectomy with radical and partial in September. Talking about curriculums, we for last 3 years have developed a curriculum in our virtual reality and surgical training lab, and technically showing that how a person who's completely novice to a Da Vinci can come in and go through simulation on ROS and laparoscopic training and go through orientation, motor skills, basic surgical skills, which include cutting, suturing, and then finally surgical anatomy, applied surgical anatomy, and hopefully in a few months a host-based procedure modules. But the biggest limitation in this field, people who have done research in this and have worked in this area, has been the cost, and this has driven high, and a lot of research and R&D money is not available for this. Da Vinci itself has come up with the backup and then the second console system, but that has had issues because of cost and probably is going to be a big limitation for them. So where will this really lead us? I think it is better selection of future surgeons, like Prokar talked earlier. Efficient and relevant surgical education is going to come in the way. Master procedures could be done before an actual procedure is performed. Rare situations can be practiced without practicing on the patient, bridging the gap and shortening the learning curve, and decrease the risk of really harming our patients. And I think that's what the future direction is going to be. 1927, Dr. Mayo said that there is no excuse today for the surgeon to learn on the patient. And I think almost a decade, 100 years later, we still are looking for the right solution and the right answer for this. And virtual reality and haptic-based reality is really going to be the future and the way to go. Thank you very much.